I'm here in one of the neighborhoods of Nairobi, and this is one of the residential areas of the city. And with me is Maureen Akolo. Maureen is a public health specialist who has worked for a number of decades creating awareness about HIV/AIDS, especially among marginalized members of society. When and how did your journey in all this begin?
What gave me the passion was when I was a student nurse in the wards around 1999-2000. We used to lose like 7 people per night to HIV/AIDS, and that was very devastating.
Welcome back to Africa Science Focus, the science and development show from SciDevNet. I'm Halima Athmani. You were just listening to our reporter Michael Kaloki, who was speaking to Dr. Maureen Akolo. Dr. Akolo is a nurse, lecturer, and public health specialist in Kenya. Having seen the devastating effects of HIV/AIDS in Kenya in the 1990s, she wanted to try and reduce the negative impact the disease was having. She has worked to increase awareness about it, encouraging people to take up treatment and prevent its spread. Much of her outreach has focused on marginalized groups who are most at risk of HIV/AIDS, including sex workers and people who inject drugs. Dr. Akolo spoke to us about how her nursing experience led her to work with at-risk communities and explains how anti-retroviral drugs, or ARVs, have transformed the lives of those diagnosed with the disease.
So my journey started when I was immediately, graduated my college. After 1 year, I started working for the key population. Key population are people who are actually very important when it comes to HIV, because there's a lot of HIV among these communities compared to the general population. So when you talk about the key population, we are talking about the female sex workers, men who are having sex with men, male sex workers, people who inject drugs, and transgender community. So I started my journey way back in 2005 by working for one organization here in Nairobi, and I worked with them for close to now maybe 18 years. Yeah. So when I had an opportunity to go and work for this particular community, I actually took it wholeheartedly, and I was happy because people came, they were very down. They had CD4s that are very, very low, and CD4 is a marker that we're actually using to know how a person is doing when it comes to the immunity against the HIV, and they are very, very low. But people could come, and then we start them on ARVs, and 2 months down the line, you meet with this person is totally different. So with that, with the availability of the free ARVs, we were able to put so many people on the treatment, and we saw very few deaths compared to 1999 and 2005. And this was actually made able because of the provision of ARVs by CDC and USAID, PEPFAR. And even also we had Global Fund coming in to actually help African countries, including Kenya.
And why did you decide to focus on marginalized members of society?
Because if you remember very well, the early 2000s, HIV was very, very prevalent in Africa, and we didn't have we didn't have affordable ARVs for people. So when the HIV tests were done, it was found that actually there was a prevalence of 29.3% among the female sex workers, and the MSM had a prevalence of 18.2%, which is very high.
MSM referring to?
Men who have sex with men, because the prevalence of HIV was very high in this community compared to the general population. And for you to close a tap of so that this water stops coming out, you have to look at the source. Where is it coming from? So the source of, like where HIV was really concentrated was among the key population. And yet the key population, as much as sex work is criminalized in the country, they are our sisters, they are our brothers, they are our sons, they are our husbands. So they are among the community. And it's very important if actually programming is taken to them so that we reduce the HIV burden among this particular population. So programming is just ensuring that we put the sex workers on ARV treatment that is affordable, accessible, and acceptable to all without stigmatizing them and criminalizing their work because they are part of the community. So with that, we have seen a lot of key population not getting HIV. The new ones who have actually just gotten into the the work of selling sex, you find that they are selling sex, but they're not turning HIV positive. Why? Because they are now in the program whereby they can access free prevention services. When you say prevention services, this includes supplying them with condoms, which are actually provided by the government. We also have what we call pre-exposure prophylaxis. These are drugs that actually taken by people who are engaging in sex, but they're HIV negative. So the PrEP helps them to prevent them from getting HIV. We also have post-exposure prophylaxis, whereby in case a client goes out and then there's a condom burst, then they'll be able actually to access post-exposure prophylaxis, which will help them protect them against getting HIV. So that's what we call programming. And if you look at what is happening currently in the program that are serving sex workers is that the HIV incidence among this population has actually gone down. You can't compare it with the time that you can't compare the incidences now with 10 years or 15 years ago. So that is what is programming, and I can tell you for sure programming has really helped this particular community. Way back in 2000, you could see patients presenting with a lot of Kaposi's sarcoma, that is stage 4 of HIV, presenting with oral candidiasis, presenting with a lot of TB. But right now, because of availability of the ARVs and the programming, it is very rare for you to come across a patient who has Kaposi's sarcoma or oral candidiasis.
HIV/AIDS doesn't just affect those in marginalized communities, and Dr. Akolo has extended her support to a wide range of people. Anne is a hairdresser who is HIV positive. We've given her this name to protect her anonymity. When she was first diagnosed, Anne struggled to accept it, and she was in denial about having the disease. Dr. Akolo helped her come to terms with her positive status and take up the treatment she needed to live a healthy life. Anne spoke to us about her story.
I met Maureen sometimes back in the year 2006 while I was still making her hair. I've been a hairdresser for many years. And so when we met, we've been interacting each and every time. But there's a day that I met her, and then I told her, Maureen, how do you see, how do you feel about me? How do you see me? Then she told me, you are not doing well. Do you have anything that is maybe stressing you? Then I told her, no, not really, I'm okay. But she kept on insisting to get to know what I was undergoing through. And I had to open up because for the first time, I knew if I open up to her being the first person for me to open up, I thought to myself it would be of help to me because she deals with the research about HIV/AIDS. Now, the moment I started telling her, she told me, oh, are you affected in any way, maybe? And then I told her, yes. I went for the family planning. in a certain facility, and I thought of myself of taking some tests of HIV. Unfortunately, I found out that I'm HIV positive, and she was, oh, sorry. She hugged me. She told me all is okay. But in my heart, I thought it is not okay, because it was not easy for me to accept the condition, Now, she kept on insisting that if I've not taken medication, I should start. And then I was like, no, it's okay. I'm just tired. I can't accept this. I've seen many people dying. There's no way I can survive. I was so hopeless.
So, and basically you were in denial at that point?
Yes, I was in denial, because I thought I've been a church person. Yeah. I've not been having multiple partners. How can I be why did God allow this to happen to me? She told me, don't worry. It is just a condition. If you accept it and take medication, take good care of yourself, you're going to be okay. In the near future, no one is going to know your condition. Then I think I should give it a try. So in 2013, we stopped the discussion, but she kept on calling me, 2014, 2015. So in 2015, it became worse. It became worse until, when a mosquito has had a bite on you, the lesions that comes on your body when you've been bitten by a mosquito, yeah. So my entire body became like that. And it was people were seeing it visible, like there's something wrong with me. So I decided to give it a try and started with Septrin. Started taking Septrin, but then still I was not at ease. I stopped at some point in 2016. In 2016 mid, I started again, because I thought I'm not being fair to myself. I need to forgive myself and just continue with the medication. Then I was introduced to ARVs, which up to now, I think they are really been of good to me.
Who introduced you to ARVs?
Maureen is the one who introduced me to ARVs. She had a meeting with me. She told me it's good and it's healthy if I start the ARVs. And I started immediately. And up to now, I'm so happy and so grateful for Maureen, because when I go after every 6 months for CD4 count, the viruses have been suppressed and I'm undetectable. I say that, but does not mean that I should now be exposed to sex out there because I'm undetectable. No, it means that I should continue taking care of myself, take my medicine at the right time, and do a lot of exercise, do a lot of healthy eating, and mentally I should be positive. Being positive is the key important thing in someone's life who has a condition. You see, getting tested is one thing, and accepting the condition or the situation is another thing.
Engaging with vulnerable communities can reduce the burden of HIV/AIDS, but how do you reach them? Dr. Akolo spoke to us about how she reaches out to sex workers.
We did something that is called mapping. Mapping is identifying where the sex workers operate. Just an example, if you want to meet Christians, you have to go to church. If you want to meet Muslims, you have to go to mosque. So you wanted to meet sex workers and you knew sex workers are there. It's a trend that has been there even since the Bible era, yeah? So you have to know where they're operating. So we knew that they're operating from the hotspots. And we did mapping of the hotspots. Mapping is just to identify where the areas are. What time do they actually operate in those areas? What is their peak? Yeah, like do we have a lot of sex workers on Friday compared to Monday? On that particular Friday, do we have a lot of sex workers at 2 a.m. compared to 7 p.m.? So that's what we did. We mapped. And then the good thing with sex workers, they are very well organized. It's a team that is very well organized. If you have, particular place A, there's somebody who is in charge of them. And the ones who are operating place A cannot actually go and operate in place B. So it is very well clear policy that they have, their own non-written rules that they actually operate, and they are very strict with them. So what you do is you work with their peers, and they'll be able to actually take you to the other sex workers. So you have to really assure them that what you're offering to them is a safe space, and for sure it's a safe space, that you are not going to call in police, you're not going to start telling people that these are sex workers and all that stuff. So they come in, and you have also even to sensitize your staff on non-stigmatizing the sex workers. So you create a safe space for them whereby they can come and talk about their life without feeling stigmatized or judged, and they will actually ask for any services that they want, and they'll get them. So what happened is it's called a peer-led outreach model, whereby we don't work for sex workers, we work with sex workers. So what that means is you bring them on board on everything that you do, including even policy making, including research, including even the programming itself, because they're the ones who are on the ground. They're the ones who are going through the life that they're going through, and they are the best people to tell you exactly what they need. For us, it's just theoretical. It's just imagining that this is what they need. But for them to embrace it, to actually accept the services they're offering, it's good that you bring them on board, talk to them, and find out. And they're very, very knowledgeable. They actually know what they want, and they even know what works for them. And the moment you work with them that way, we have seen that things are actually working, very, very, very good. So we have the peers. The peers are on board. So these peers are the ones who actually link us to their other sex workers. So we work at the community level, and we work at the facility level. So at the community level, we go reach out to the ones who are the hotspots. We call them hotspots, where they're operating from. And at the hotspots, what we do is you take their prevention services and clinical services. For those ones who are willing, they actually take up the clinical services. And then you actually refer them now to the facilities to show them that in case of anything, in case you need a service, maybe it is during the day and you're not working, you can actually walk to this facility and get your, like medication or any health service that you need. And these services have been, they've been funded. So actually they get the access the services for free. Yeah. So far we've actually reached close to 45,000 female sex workers in Nairobi, around 10,000 men who are having sex with men, and around 2,000 transgender people. I wouldn't talk so much about people who inject drugs because there's another partner who's handling that, and haven't done much work with we call them the PWIDs, people who inject drugs. Yeah.
So since you started working with the sex workers to create awareness about HIV/AIDS, have you seen a change in their general attitude amongst sex workers since you started several years ago towards this disease?
So one thing for sure, I'll say that right now, HIV is not stigmatized the way it used to be stigmatized long time ago. When somebody gets HIV, you'll see that they actually embrace even treatment. I'll tell you, when HIV came in and it was so rampant, somebody had to take a test, which was called ELISA, and you had to go home for 2 weeks and then come back for your results. There are people who never used to come back for their results. There are people who actually went and killed themselves because they knew that that time it was called a slimming disease. So the moment you get it, you're going to start slimming and then you are going to die. So it was like a death sentence. With time, we have gotten tests that you can actually instantly get your results, receive your results. But before 2016, what used to happen is you get tested, and because it used to be stigmatized, you are told you're positive, you are given 2 weeks to go home, go and think, and then come and start your medication. So you're not started on medication immediately because we used to understand that it is a shocker on somebody, so they needed time to go and think, then come back. And we had so many people who never used to actually come back. But with time, the government changed the policies, and we started a policy that is called test and treat in 2016. So what that meant is today, if you test positive for HIV, you start your medication today. So there's no that window period of you going to think and all that stuff, because we realize that you give people time to go and think, and they actually disappear. By the time they come back, because they're in denial, they come back when they are really wasted. So right now, it is not, you can see a change of attitude towards the disease. It is not so stigmatized, still stigmatized, but it is not so stigmatized. You'll see somebody testing positive and then they say, I'm ready to start the treatment. And you put them on treatment and they continue with the treatment. Now, because we don't have people changing, slimming down, we don't have people getting Kaposi sarcoma. TB is still there, but not as rampant as it was during those days when there were no treatment. So it is the HIV disease it's less stigmatized. Again, something else is the treatment, the drugs that we used to have some time back. We used to have a drug called stavudine, also known as D4T, that could cause lipodystrophy. Lipodystrophy is when fat is transferred from one part of the body to another. So it was so evident that somebody is actually on ARVs, and it was doing a lot of, destroying the cosmetic appearance of people who see the face, the cheeks going in, looking like they've been sucked in, and then somebody develops a hump, like a back hump, and then the legs and the hands thin out and all that stuff. So somebody could easily tell that this person is actually on drugs. But with time, we have very nice, friendly drugs. We have pills that somebody just needs to take once in a day, and the side effects are very, very less. So we can see that people have really embraced HIV management and treatment, and they are not so stigmatized compared to 10, 15, 20 years ago. So it's something that you can actually look at, and you wouldn't even tell when like the way we sat here, the three of us, we wouldn't tell who is positive and who is not positive, who is on drugs and who is not on drugs, because it has just become part of life. So it's not a big deal. Yeah.
So what impact does the work of people like Dr. Akolo have on the communities affected? We spoke to Josephine Munyambo, a community health educator who is experienced in working with people with HIV/AIDS.
The work Maureen does has a very great impact because she helps the people of HIV/AIDS. They come out openly, talk about it, and about being infected by the virus.
Now, Josephine, Maureen also goes out to speak to sex workers. You also have experience working with sex workers. What impact does it have when people go out to speak to sex workers? From your experience, what impact does it have on them?
Most of the sex workers, they create jokes about it, but when you talk to them openly, they open up their mind and they talk about it openly, and they are
open about it.
They open up about it.
You work in a community where people have, go out, such as Maureen, to speak to community members. From your experience, does it help bring the rate of HIV/AIDS infections down? Does speaking to them, creating awareness, does it help bring infections down?
The creating awareness has brought in the impact of bringing the virus down. It has come down now because people are enlightened.
Dr. Akolo has worked for many years to improve the HIV/AIDS situation in Kenya. We are going back to her to discuss the changes she has seen.
Personally, I can say that I've had a lot of impact. One, on the population itself, the sex workers. We have done a lot of work with the sex workers. We have actually ensured that they even have their advocacy groups, that they advocate for their rights. We've ensured that we have those ones who are positive, who have come out to talk to people, champion about HIV and the importance of even taking treatment. And through that, people have actually, the ones who are feeling that they are stigmatized, the ones who are feeling that they need to hide, they've actually come out and even taken their treatment. And that means that even the HIV incidence and the prevalence among this group has really gone down. I've also had some junior colleagues who have actually mentored through a lot of things, programming and all that stuff. And they've really done well and they've gone far. As a faculty member also, I've also mentored my students.
Or you teach at a university?
Yeah, so I also teach at a university here in Nairobi. And also mentored members, some students who are actually doing so well in research, in HIV research and all that stuff. I've also done a lot of research work for those 18 years and I've traveled the world just to showcase what is happening in HIV among sex workers in Kenya. We've come up with interventions that have really worked. We have trained a lot of people across the country in PrEP, exposure prophylaxis, in some evidence-based programs called EBAN-K, positive health and dignity prevention. Those are just some of the evidence-based interventions that we've actually taught our population of HIV. Apart from the sex workers, we were very interested in looking at the discordant couples. Discordant couples means that one person is HIV positive, the other one is HIV negative. We managed to bring together around 570 couples who are in a discordant relationship, and we used to, train them on how they can actually remain in their relationship, but still remain discordant without infecting the other person, and even how to go about if they want to get children still and remain in that particular discordancy without infecting the other person. So I can say personally that we've impacted a lot of lives from HIV positive individuals, from the HIV negative ones, from the discordant couples, from students, and even my junior colleagues.
And since you started working with the sex workers, have you seen a drop in prevalence rates amongst them?
So from the government side, I wouldn't say that we have there's prevalence and incident records that have been actually conducted for the whole country. But from the sex workers programs, I can say that we've really seen that they have embraced prevention, and the seroconversion rate is very low. What I mean by seroconversion is the ones who are negative, they're actually remaining negative in the program. And the ones who are positive, you find that even their viral loads are very, very minimal, that they cannot even transmit the virus. What do I mean by that? We have something called that U is equals to U. That simply means that once your viral load is undetectable, then it is untransmittable. So the ones who are positive, they're taking their medication, they're suppressing their viral loads, not able to transmit it. And the ones who are negative, they are actually embracing the prevention arm. They're using condoms, they're using PrEP, they're using PEP, and they are remaining negative. So it is the number of sex workers who are actually getting HIV has really reduced by far.
That's all from us at Africa Science Focus today. If you want to find out more, head to the SciDevNet website. That's www.scidev.net. Today's show was produced by Alice Hurst with editing by Ruth Douglas and reporting by Michael Kaloki. I'm Halima Athmani. Do you have any comments, questions, or feedback about our podcast episodes? Let us know at podcast@scidev.net. Africa Science Focus is produced by SciDevNet and distributed in association with your local radio station. Until next time, goodbye.
This project was funded by the European Journalism Centre through the Solutions Journalism Accelerator. The fund is supported by the Bill and Melinda Gates Foundation.